All right, so we went over the handbook, which is pretty boring and not that fun and all of that, but all important information. Susan's going to come later and she's going to talk about policies and procedures, which is also not that fun or anything. But we're going to talk about dementia, which is probably, other than my kids, is my favorite subject. So, and I do believe I got into this because I fell in love with seniors, and a lot of seniors have dementia. I fell in love with them when I was in high school and started as a CNA. I heard you say, when did you get your CNA?
In 1989, and back then, there was no such thing as going to college to get your CNA. I got mine in a nursing home free. They used to do that.
So I was 15 when I got my CNA, and we went to the nursing home. So it was probably like 1990 or something. So I've been doing this a while too. So, but anyway, what we do is so important, and it's never going to be replaced by a computer or anything like that. And how we interact is key to whether things are, we have a successful and a positive interaction, or it's negative and we're in a battle and all of that kind of stuff. So we're going to kind of do my dementia basics class today, and then we do ongoing training over the, throughout the year. So, all right, so how many people have dementia? Have you ever heard the numbers for that? Every 4 seconds, someone is diagnosed with dementia. Every 4 seconds, which is hard to imagine. I can send you these slides if you. And this, I got all this information from the World Health Organization. So, I feel like that's a pretty reputable source. 50 million people have dementia today. And by 2050, 135 million people will. So thinking about the implications of that for, in so many different ways, not only in our community, but worldwide, and the financial implications of that, and the shortage of caregivers that we already have. We've got to do things better and figure things out. The other thing is 1 in 6 women have dementia, and 1 in 10 men that are living past 55. And basically that comes down to the fact that women just live longer. So important information to kind of lay the foundation for where we're headed is something you learned in grade school. People take in information through their senses. That's how you take in what is communicated to you. So first thing, vision, what you see. What else?
What you hear.
What you hear.
What you feel.
What you feel.
What you smell.
What you smell.
And taste, okay.
And what you taste.
Okay.
So we're not going to worry so much about smell and taste. A lot of times those are very diminished later on in life anyway, and they don't affect as much our interactions. We're going to work on vision, hearing, and touch, and we're going to do it in that order, because as caregivers, a lot of times we like to jump right into touching somebody, but we need to do some other things first. So, like I said, visual data is the most important. People living with dementia, and just people in general, pay more attention to what they see than what they hear or what they feel. So think about if a door slams, you hear it, but then what happens? You turn to look. So you rely on that vision to support your taking in information. A lot of times we go into touch as caregivers. The other thing that we do as caregivers is we spend a lot of time on this, talking. One thing we do is if somebody else doesn't talk, then we just keep talking to fill the space. And so what happens is they, if we ask a question, they're trying to process what we're saying. And if we get uncomfortable because they haven't responded right away, then we just keep going into it. And so they don't have time, if they're trying to think about how they want to respond and that takes longer to process, if we keep talking, then they start on the next thing and they can't follow where we're going. So we'll talk later about how we need to ask a simple question and then just shut up for a minute and give them time to process what we're saying and reply. And not every time that works, but you're increasing your odds of that being successful rather than if we just keep talking. All right, so something we'll talk about later also, but you want to make sure that you don't touch until you have that visual and verbal communication with that person. So don't go into the touch. And what do we do a lot of times? We come behind them and rub their back, or we rub their arm. We're doing it in a comforting or that sort of intent. But if they don't know who's there or what's going on, that's going to set you up for a potentially negative interaction. And we're going to talk about using hand under hand later for how we do some of our interactions, but we'll kind of practice that a little bit later on. So what is dementia? In your books, if you want to look at, we're towards the back here. There's an umbrella. And so if you look at that umbrella, it's kind of a nice visual of people get confused and they say dementia and Alzheimer's they use those words interchangeably. Dementia is the umbrella where all the types of dementia fit under there. So there's over 100 different types of dementia. You don't need to worry about that, just look at hers. There's over 100 different types of dementia, and Alzheimer's is kind of the most well-known brand of that. Our job is not to diagnose. Our job is to look at what signs they're showing us and respond to those. So if somebody is having strengths as far as their verbal, but they need more help with the physical stuff, that's what we're going to help support. But if somebody with Alzheimer's is physically able to do stuff but doesn't have the words, then we're going to try and support that verbal communication. So even if somebody has the same type of dementia, they might have totally different needs. So what happens to the brain, it's a chemical as well as a structural change. So you have cells that are dying, you have chemicals that aren't being transmitted how they need to be, and that's why you're seeing those changes. So if you have a time, sometimes you notice that everything kind of works, like they're able to communicate or they're able to walk, and other days they're not. When that's working, that's because everything's lining up. The chemicals are being transmitted, and so you need to just enjoy those times. As families, they need to enjoy those times, and as care partners, we need to just take advantage of that. So if they're able to do that, and we know that they love to dance or they love music or whatever, we need to capitalize on that and enjoy those moments with them. So there's 4 truths about dementia. At least 2 parts of the brain are dying. It's chronic and it can't be fixed. It's progressive and it's only going to get worse. And it's terminal. So if they don't have, a lot of our residents have multiple medical conditions. And so they may have something else that is a health condition that is the reason that they pass away. If not, dementia will eventually rob them of all of their abilities, and that will be how they die. So we already talked about the dementia umbrella there. There are some things that can mimic dementia. So sometimes, I think you've all probably heard when somebody's out at the hospital, they, their family's like, oh my God, she was a mess. She didn't know anything, blah, blah, blah. So couple things. Delirium would be that stuff that you see like when they're in the hospital, when they have an infection, when they have that kind of stuff going on. Depression is another one. And so depression and dementia are very closely related. And that's why you'll see a lot of times people with dementia are on antidepressants. And so a lot of times that apathy or that lack of motivation or initiation is dementia. And we're thinking it's maybe progression in their dementia, but it's actually depression that we're seeing. So, and we really don't have a way of knowing which one it is, but it's always a good thing to start with as far as trying to eliminate. When somebody has a change in cognition or ability, we first start with, do they have what?
An infection.
Yeah, so what do we do?
Yeah.
We get a UA, because that's an easy one to do, We get a UA, we look at medications, have there been any med changes? Then we think about depression, and they can't tell us. They can't say necessarily it hurts when I pee or, any of that kind of stuff. So we have to be extra observative and communicate so we can get that picture of what might be going on. This is a picture of brains here. So we've got, this is a child's brain, like a young child. This is what an adult's brain looks like. So young child, you can see there's not a whole lot of red in there. Red means hot, so there's stuff happening there. So in a normal adult, this is what you're gonna see. See all the red? So everything's working. There's all this heat being produced because things are happening. This is what early dementia looks like, and there's still a fair amount of red there, so there's still a fair amount happening. But if you notice in late Alzheimer's, it really goes back to what you see as a young child. So, and we never want to treat them like they're a child, but it's good to know kind of the progression that we're seeing as far as what is actually happening in the brain. There's a picture just to see the structural changes. So we'll see some other like cross sections, but you can just see all the spaces in between there. So, things aren't able to communicate as effectively. So brain atrophy, the brain is shrinking, we can see that. The cells are dying. In Alzheimer's, a lot of times it's a pretty predictable progression, but like I said, it still looks different for every person. And that's what's challenging a lot of times, I think, for families, because they can't say, my friend had this and this is what happened. Sometimes it'll kind of follow the natural progression, but other times not. So that can be really frustrating and challenging. And then when they have a day that they're better and everything's working, then they get that hope, oh, maybe she's gonna get better, and that, that's not possible. Vision is where we see the largest amount of changes in the brain and in function. So everybody stand up. I told you were gonna have to move around a little bit, so we're gonna start now. So everybody stand up, and I want you to do some, what do they call these? They're not helicopters, but let's just pretend. So, all right. So when you're 20, none of us are 20, so, but when we were 20, we could see everything, like put your arms out and wiggle them. This is our field of vision when we're 20. That's why they are a lot more fearless. They've got a lot quicker reflexes, they've got this wide field of vision, all of that kind of stuff. By the time you're 40, bring it in about 20 degrees. And that's about my age, and that's about where I can see my fingers moving. this is where your field of vision is. Still pretty good, but you know, as a normal-ish 40-ish-year-old, that's my field of vision. And I can still drive pretty well and all that kind of, I mean, depends on who you ask. But by the time you're 70, go in another 20 degrees. And that's where your field of vision is. And so this is normal aging. This is where their field of vision is. So by the time somebody, so this is why they start driving a little bit slower. They are a little more cautious, you know, all of those, my husband always complains about the Sunday drivers, you know, but there's a reason they drive slower, because they need a little more time. They don't have this to rely on. By the time somebody is early dementia, put your hands like goggles, not like binoculars, but goggles. This is where their field of vision is. So if we talked a little bit earlier about if you come up from the side, so put your goggles on. If you come up from the side and rub, can you tell I'm here? No, you can't.
Can you see her?
Oh, no. Right, if I came up from the side, you wouldn't know who's touching you or why, and you know, that reflex kicks in, and so what might you do? Because if somebody's trying to get up in your business, you're going to respond. So by the time they're middle stage dementia, we're going to kind of talk through these different stages. Here's where we're going to be. We're going to be binoculars. So think about all of the things that have to happen during a day. So if you've got binoculars on and you are trying to eat, if you're focusing on your meal, you have no idea there's anything else happening. And then once you focus on if somebody's talking to you, then you forget all about the food in front of you. So, you know, it's good to think about that when families want to come and they want to have a lively dinner conversation and they want to, have this interact. So either they're upset because they're not eating or they're upset because they're not talking to them. Well, that's not their fault because they can't do both of those things. They can do one thing or the other. So sometimes talking to them about, hey, maybe it's better to come before lunch or after lunch, or bring ice, a milkshake, which they could do while they're, by the time you're end stage dementia, you're down to monocular. So you're down to one eye. So that's because the brain's not able to balance between the two eyes anymore to communicate, so it just goes down to one eye. So that's when you're going to see if there's a plate in front of you, if they're still able to do some of their own manipulation of meals, that's when you're going to see half of the plate has food on it. They might eat this half, but this half isn't here, so they don't eat that side. So it might not be that they don't like what's on this side, and if you turn the plate, then they eat it, but that's why that potentially could happen. So
Never knew that.
that's why you're here. Yeah. Okay, have a seat. So I think just knowing that information, what are some ways, so kind of going through that, what are some ways that you can incorporate that into your interactions with residents?
Coming in front of them and turning that plate constantly. Or the cup or okay.
And thinking about when you are doing an activity, maybe doing more like having mealtime, or when they're doing toothbrushing or hairbrushing or whatever, don't spend a lot of time on the verbal, so they can focus and concentrate on the activity. So it's not that you're being rude by not conversing. You're trying to give them that time to focus and complete that task. So. Okay, so this is a cross section of another part of the brain, and you can see the big changes here as well. There's big holes there and all of that kind of thing. So what starts happening is that they can't understand the words. And so when you're talking to them, keeping it as simple as possible is the best thing because it gives them a better chance to understand. Don't use big fancy words or don't use slang, or keeping it simple, short phrases. Or they miss some of the words. So they might get, if you have this big long speech, there's more, they're going to miss more of it. So keep it simple, short phrases. And they get off target. So if you're talking together, they're going to talk for a little bit and then they're going to kind of go off on a tangent sometimes. They do very, very late into the disease, they still get the facial expression. So the best thing that anybody can do, and I tell when kids come to volunteer or people that are just not familiar with this environment, the best thing you can do is smile. If you look like you're annoyed and you don't want to be there, they can sense that. So the best thing you can do is smile. They can hear the tone of your voice. So if you sound annoyed, they pick up on that as well. And they can get some nonverbal. They do early on, they learn how to cover up. So they'll say, oh, honey, or, they still have a lot of that kind of social pleasantry, social chit-chat kind of stuff. So, if you're asking them, the other thing is you don't want to make everything a quiz. Like, do you know who I am? Or do you know what you had for lunch? Or families are notorious for doing that. What's the point? What's the point of giving them a quiz to see if they know the answers? The only thing you're going to do is make them feel uncomfortable and question, even if they do know what they had for lunch or do know who you are, then they're going to think, well, I don't know, I hope that's the right answer, just make it easy. So if you're coming to see your mom, you go in and you say, hi, Mom, it's Michaela. That sets yourself up to have a good interaction rather than, do you know who I am? Mm-hmm. Remember what kid that's not going to make anybody feel good. Because if they don't, that's going to be disappointing for everybody. Sensory changes. Look at the difference in those. They lose the awareness of their body position. So a lot of times you'll see somebody that's sitting in their wheelchair and they're like this, and if you come and say to them, hey, can you sit up straight? They're like, yes, and they sit up, but they just don't have any awareness of the fact that they're leaning totally over, or they're like this in the wheelchair. It's not that they can't, but their attention span is very short, and they just kind of forget about it. They aren't able to locate pain. They aren't, you can kind of look and you can see they're grimacing or they're doing, something that they typically do when they're uncomfortable or needing something, but they can't say, my back is killing me. That's what we would say or I have a terrible headache. They can't say that anymore. So they might be able to rub or something like that, but they aren't able to pinpoint this is what's hurting. And they lose the feeling in their body. So that's why one thing that does happen, especially if they're kind of still being, if they're in assisted living and are doing more things on their own or they're at home, is they might have this big pressure ulcer on their heel or on their toe or something because they aren't able to say, these shoes hurt or something's wrong on my foot. And so if they always have their socks on, and are doing their own, doing or not doing their own hygiene, those kind of things get missed because they're not able to communicate or to even recognize that that's going on. As the disease progresses, they do get hypersensitivity. Their mouth is an area that becomes hypersensitive, and so sometimes you'll see them putting everything in their mouth. They also can be hypersensitive in their genitals, and so a lot of times hygiene, toileting, that kind of thing can be a stressful time, but that's because that's an extra sensitive area for them, and then their feet and their hands also. So Self-care changes. So again, I mean, huge changes in the brain structurally. They lose the ability, two things. They lose the ability to start a task, and they also lose the ability to stop a task. So we have a guy at the farm that once he gets started wiping, he'll wipe for hours. I mean, there's nothing to wipe, but that movement, once he gets it started, you have to physically stop him. The other thing is initiating, like getting started brushing your teeth or getting started, and that's why we have to help with those cues and the setup and all of those things to start, and then eventually we have to get them started in the movement. And once they get started, again, they might not be able to stop it, so then we have to help stop it. Tool manipulation. So they'll take, the classic one is they take the toothbrush, and guess what they do with it? Hair, you know. So it's close. I mean, it's a brush of some sort, but it's not they use it for their hair rather than their teeth. So that's a big one. Or they take the deodorant and they put it on their hair instead of on their arm, underarm. And then sequencing. So thinking about, if I tell my kids to go brush their teeth, I know they know how to do it. They don't always do it, but they do know how to do it. And to us, it seems very simple. But if you think about, so what are the steps to brushing your teeth?
Putting the toothbrush, put a toothpaste on your brush, turn the water on, get your
Okay.
water and your mouthwash, brushing teeth,
Mm-hmm.
tongue.
Yeah, so that, I mean, if you say it like that, it's still a lot of steps, actually. But first, you got to find the toothbrush. Then you got to take the lid. Then you got to find the toothpaste and take the lid off the toothpaste. Then you got to put it, So if you break it down even further, that's where that sequencing gets off. So they still have the motions, but they just aren't able to put all the steps in. And so that's why we want to encourage them to still do for themselves as long as they can and support them with cueing. Language is a huge one. So everybody stand up again. I like to use little cues whenever I can, just because it helps to make it stick, I think. So take your left hand, put it on the left side of your head, and say language on the left.
Language on the left.
Then take this hand, your right hand, put it on this side, say rhythm on the right.
Rhythm on the right.
So let's do it again. Language on the left, rhythm on the right. Lose on, I'm switching it up. Lose on the left, retain on the right. Lose on the left, retain on the right. So when you're thinking about the brain, language is on the left side. That's something that normally is lost. Rhythm on the right is rhythm. So like if you think about when the music therapy comes or when we do music, that's sometimes when things kind of click, and people that you would never guess would know the words to a song, like that comes back. So especially old songs that they know, that rhythm, they're able to clap their hands to the beat or shake or, whatever. The other thing that stays is on this right side is the forbidden words, the things that you hear, when you're a kid, you hear a bad word and your mom's like, oh, don't ever, don't say that or don't, so you take that and you put it in a special place so that when you get old and have dementia, then you start just throwing them out there. So left side is language. We're going to talk about the language changes. The right side is where the rhythm is, the, marching. A lot of times they can still do the marching to the beat and clapping and all of those kind of things. But, and then those forbidden words are on this side. So, okay, you can have a seat. So on the right side, a lot of times they start having word salad, and if you guys spend a lot of time in, that's right, thank you. If you have been in Harmony a lot, we have a few examples of people that just have that word salad. Like sometimes they'll put something together, but they either, the words don't make sense, or they're not in the right sequence, or they get started and then it kind of just falls off. We talked about the vague language, kind of the, oh, honey, or well, I did it yesterday, or whatever. They get to where they can't make their needs known anymore. And so that's when when it's so important that we know them, and we know when they get up pacing, usually that's that they have to go to the bathroom, or we can look for those signs so that we can go through our checklist of what might be causing this anxiety, or what we're seeing. They still have the singing, the automatic speech, the pleasantries, or hi, how are you, that kind of stuff that you learned way back. And like I talked about, the naughty words that you learned that you're not supposed to say, those stay. And so when they're put in a stressful situation, that's when they're gonna let her rip. All right, so let's talk about approach. So Teepa Snow is an occupational therapist that's kind of devoted her life to making lives better for people living with dementia. There's a lot of brilliant people that are working to come up with a cure for dementia. Our place is to make things as good as we can for those people that are living here now that aren't necessarily going to have the ability to benefit from that. So I'm going to have Shannon, why don't you come be my assistant? So we're going to talk about the things that we've applied. What are the things that we learned? How do people take in information?
Touch, sight, hearing.
Oh yeah, sight, that's it, same thing, yeah. Okay, so we're gonna use those three, and we're gonna talk through each of them and kind of how we put it all together to have a positive interaction. So the first thing you wanna think about is you wanna start in public space. We like to get up close and personal right off the bat, but that's not the best way to approach somebody even if we know them, if they don't know that they know us, we wanna gain their acceptance into their space. So let's start at 6 feet away is considered public space. So that's like, a full-size, a large, tall for full-size person's distance. So we're gonna start at 6 feet away. And what we wanna do, what's the thing that we can do, the easy thing we can do to set up a positive interaction?
Smile.
First thing we're gonna do is smile. So when you come to work, leave all your baggage. Your kids are driving you crazy, you got a speeding ticket, whatever it is, leave that at the door. So when you come in, you're here and you're positive and you're ready to have a positive interaction. So when we're gonna interact, we're gonna start at 6 feet away. We're gonna smile and we're gonna put our hands up. So I'm gonna say hi. If we are really on our A game, we're gonna have our name tag right here that says our name. So if you can still read, if you're able to read that, like we have some people that love name tags and cards because it's a cue for them and they've learned that. And so if you can read and you can see my name's Michaela, that makes you feel like you're kind of in control rather than thinking, I don't know who this chick is. She's got blonde hair, she's smiling, but so might set you up to be successful. So we're gonna start here. We're gonna put our hand up because everybody learned to wave when you're a baby, right? You learned your mom taught you how to wave or whatever. And then I'm going to, if she's looking, she's probably may or may not wave back at me, but I see she sees me. And then I'm gonna put my hand out because we also, well, you don't come in.
Oh.
You're the person with dementia.
Okay,
Yeah,
dementia.
I didn't tell you that part, yeah. So then I'm gonna put my hand out And what did you learn to do when you were young? Your grandpa or your, whoever taught you how to shake hands. So what's this person hopefully going to do?
Put my hand out.
Put your hand out. And that invites me into your space. So now we're in personal space, which is like, I'm going to have you come here, which is like 3 feet. So now we are engaged. I'm closer. So if I'm standing straight on, think about if you're middle stage dementia, you got your goggles on, or not goggles, you binoculars on. What do you see?
I see your face.
Just me, basically. So if you were sitting, let's do that. If you're sitting in a wheelchair or whatever, now what do you see if I'm right in front of you? My stomach or sometimes my boobs, right? Like, so it might give you some bad ideas or, so what I want to do instead is so that it doesn't feel like I am in a kind of an attacking or I'm in a power position. Maybe again, just so that okay. I'm going to step to the side and we're back in our stance. I'm going to step to the side so you can see some space. So it's not like I'm overpowering or whatever. The other thing I'm going to do if she's sitting is I'm going to get down on her level. So then it's not like I'm in control and I'm going to tell you what to do. We're in this together. So when your hands are in the handshake, then you can take it and move it into hand under hand. So you go into like the, makes kind of like a butterfly shape or something. And then you close the hands and it puts hers on top. The reason that's important is because then it becomes, I'm not in control, she's in control. So she's the one that is in power, not me. Because nobody wants to be out of control. Nobody wants to feel like they are being treated as a child. We do have to do some things during care, but we want them to feel like they are empowered and have some choice. So we've got her hand on top, so she's in control. This is really important when we're working with somebody. We'll hold hands later, but we can stop for now. This is really important when we're working with somebody that has middle to later dementia, because we can use this hand under hand technique to do a lot of these activities of daily living that we sometimes struggle with. And so what are some things that sometimes are a challenge? Showers. Okay. What else?
Feeding, changing.
Okay. So what we want to do is we want to put that person in control. So if you're talking about eating, so let's have you slide up to the table. All right, let's scoot down a little bit because we're being videotaped.
Okay.
So so we've done all our stuff. We've got into our hand under hand. So what I'm going to do, here's your lunch. Here's your silverware. What I want to make sure I do is that when we're doing hand under hand, I want to get on your dominant side. So are you right-handed? Mm-hmm. You felt like you were right-handed. So, and as I'm assessing, I'm looking at your probably middle stage dementia because of your vision, your verbal, your motor abilities, all of that. When you are, as the disease progresses, you lose skill. So these 3 are your skill fingers. Go like this. These are your skill fingers. These are your strength fingers. And so you think about this stuff you lose in your skill, but you keep your strength. So think about these little ladies that weigh 70 pounds, but they can have the death grip on the wheelchair or the handicap bars in the bathroom. And you're like, how is this possible? Because that skill is retained, but they don't have this, or that strength is retained, not skill. They don't have the skill anymore. So they, once they initiate holding on for dear life, they can't initiate letting go. So it's that same concept applied again. Okay, so we're here. We've gotten, we've bonded. We've done all of that. We're going to have lunch. So here's your dinner, here's your silverware. We're in the hand under hand, so your hand is on top.
Mhm.
I'm gonna take this hand right here, and I'm gonna put it on your shoulder. The reason is you want to give yourself all the opportunities to tell the brain something's happening over here. We've got some activity.
Mhm.
So if I put my hand here in a firm, not hard, but you don't want light,
Mhm.
you want to, that'll help tell the brain we've got something happening here. So let's try and keep our focus.
Okay.
So you got your hand here, you get close, so you can manipulate. And then you take the spoon and you're gonna put it in her hand, not in yours.
Okay.
So, we're gonna be doing a lot of the work initially, but it's gonna feel like she's doing it. So when you go to get a bite of food, you wanna make sure all your movements are exaggerated. So when you go to get it, you wanna take a big scoop. So we're getting mashed potato, I don't know
Okay.
what sounds good.
Goulash.
We're having goulash today. We love goulash. We're gonna take a big scoop and we're gonna bring it to the mouth. And it's gonna tell the brain something's happening here rather than me just shoveling it in and wondering why she's not opening her mouth. And so she's gonna open her mouth. There you go, goulash. Now, first I would have told her what she's having, but that helps to tell her brain what's happening there. So then she should chew. Now, one thing that does happen is that initiation, all of that kind of stuff. Sometimes they forget to swallow.
Mhm.
And so if you're seeing that happening, what you want to do is you want to go through the motions of taking the big scoop and bringing it up, but don't put anything on the spoon or fork or whatever. So take kind of like a false one
Mhm.
and bring it up. And that tells her, okay, I'm gonna open my mouth, I'm gonna chew, and then I'm gonna swallow. So a lot of times that'll get them to do that next step.
Okay.
So, does that make sense?
Mhm.
Okay,
I like that technique. I never. Yeah.
yeah, and so, it takes a while to get comfortable doing it. You can do the same thing with drinking.
Mhm.
You can do it with brushing your teeth, using, like just thinking about if we're brushing our teeth, this is a toothbrush. You get started. Sometimes you can back off and let
And
them
they
finish.
Okay.
Sometimes you can't. And, they have a very short attention span. So you might have to go ahead and get them started again if they kind of lose that rhythm of eating. And, sometimes you got to turn the plate if because that skill is gone. So they have the strength, but they might not, their aim, and their vision is impaired. So you still have to be there to kind of help everything work.
Mhm.
But think about that feeling of accomplishment rather than me trying to shovel in food and you won't open your mouth because you have no idea what's happening.
Mhm.
And so, does that make sense?
Yeah.
Okay. All right, I think I can turn this one on.